So that's all right. I think I can remember the the list. So first, I'd like to thank all of you for staying to this late in the afternoon. It has been a long and I think pretty stimulating day. But no matter how stimulating the day, when you're 8 or 9 hours into it, it begins to drag a little bit. So I very much appreciate your attending. And on behalf of Kathy and I, I'd like to thank the Planning Committee for all the effort they put into bringing the day off. Also, I'd like to thank, on behalf of the Planning Committee and the Roundtable as a whole, the speakers and the moderators for their really wonderful contributions to the day. Hopefully you all will leave the room with new things to think about when you go back to your organizations. Especially, I'd like to thank the folks from the Roundtable that have made this possible. So Meredith, who ran multiple calls, Sarah, who pinch hit during a number of the calls when Meredith couldn't be there, Siobhan and Michael Barrios, who's been involved, Siobhan, Annie. These events are only loosely chaired by the co-chairs. they're mostly chaired by the Roundtable staff who really make it work. So I'd like to thank all of them. So that was buttering up Siobhan because and Meredith, because they spent a fair amount of time, I think Sarah did too, sort of putting together bullet points for each of the sessions, which we are going to now largely not go over. There's a lot of material here in each of these. And I don't know if there's a mechanism for sharing some of this content from these sessions with attendees that are interested, but certainly you can take a look at those at your leisure. Lots of information. I think I came into the day thinking it was going to be a mile wide and an inch deep, and I think it ended up being 3 miles wide and 3 feet deep, which translates to one's head wanting to explode. I don't know if you have additional thoughts along those lines.
Good, yes.
So anything to add to that before we talk about? Okay. So just to conclude, and I'll make this fairly brief, Kathy and I spent some time sort of going over what we think are overarching issues that have come from the day, and then possibly some ideas that come from those overarching issues to the roundtable moving forward to consider. Absolutely, this is not a complete list. It is, given the rapidity with which it was put together, probably a half-baked list, but let's start. So first, I think it is abundantly clear from essentially every presentation, or every session at least, during the day that there's a need to increase underrepresented populations and their inclusion in data. None of the material being put back to patients can be said to be complete if those populations are not included, whether that is in the realm of DTC information or in clinical testing, frankly. We don't have the information we need. So next, we really need to think about facilitation of utilization, movement, and upkeep of genetic information over space and time, and what the roles and responsibilities of the various actors are. It was hard enough to think about that in the traditional medical model and clearly hadn't been ironed out, but the DTC advances have added a new wrinkle to that, and new players on the table that may have a role in being the source of longitudinal upkeep and interpretation of genetic information. I think we need increased transparency regarding the benefits and limitations of the data that can be understood by all patients and providers when that data is put back in their domain. And that information needs to be informed by what is known and what is not known about the results that are returned. There probably needs to be some increase in transparency around data security and sharing policies for patients and healthcare providers. Some companies, I think, do a fairly good job of that at this point in time. They probably do a better job if you have a degree in law in other cases, and in some places probably there isn't even much put forth by some companies about what exists for security and sharing policies. Increased clarity of regulation in the space of genetic testing is important. That's important for DTC testing. It's important for traditional genetic testing models. Increased clarity and transparency of protections for the individual consumer in terms of discrimination and or security issues, how their information is being used is important. So I guess I want to make a distinction there. The security I talked about in the previous bullet point was really about just, is it hackable? I think there's another level of security, which is, could that information be used by a third party that you may even sort of know about having your data to potentially result in adverse outcomes, which I think Jameson Voss began to raise in the questions he asked. So the next, and I think last, was it's pretty clear that we need a better knowledge of current and ongoing or newly coming on board consumers of DTC and consumer genomics, and what their attitudes and interests are moving into this space, and what their views are on secondary uses of their information, and how that information gets integrated into clinical care. I think at this point, we largely have information about early adopters. We need to find a way to begin to segment the populations that are using these services more effectively to understand if there is change over time of who of the folks that are taking up the testing, what their thoughts are in comparison to those early adopters. That may be a tall task, and we're always going to be behind the curve in that, but I think we need to know more than we need to know something that's more current than 10 years old data, essentially. Okay, so anything to add? No? Fair enough.
Except
oh, sure.
I feel compelled that we should show the slides
sure.
that Meredith put together.
So session 2, I'll let that up as I'm rambling about the roundtable activities, and then I'll click partway through, or maybe you should remember to do that as I'm rambling.
Yeah, I will do it as you're rambling. I was going to say one more thing, though.
Sure, go ahead.
I was going to say something to the last point that Greg made, just about doing better research studies on the population that's currently using consumer-driven genomics, because I really think that's going to be important when we think about, like, is there actual penetration to underserved populations, which I'm not sure we still really know the answer to that question, and is it really increasing access? And I think that's still an really unknown. Is it making it more it's making it more accessible, but to whom? And is it really penetrating some of the populations that we clearly need to be engaging with and having involved in this if we're ever going to do a better job at getting a better evidence base and better interpretation? So that was one thing I just wanted to add. And then I will go to session 3 so they can read that now.
Excellent. So in terms of potential downstream roundtable activities, so I think it might be interesting to explore approaches for incentivizing addition of at least the subset of data that relates to underserved populations into more publicly accessible databases from companies. We've sort of danced around this issue in a variety of different forms. I think the DTC angle and consumer-directed genomics angle offers another potential lens with which to look at this issue. Next, looking into potential ways of facilitating connections between community groups and educational resources regarding DTC testing. I think Vince brought this up, and then there was further discussion about it. The Roundtable has been a good matchmaker in the past between groups that don't ordinarily get together in the same room to think about how they might leverage resources. This is something potentially the Roundtable could play a role in. Another area that the Roundtable might be able to have an effect on would be in the area of developing, helping to think about developing systems to support providers and patients in the event that an actionable result comes back from DTC testing, essentially trying to help think about ways to reduce the gap or chasm between that DTC result and engagement to the smallest delay possible. So there was a fair amount of intriguing conversation around finding ways to incorporate risk algorithms for error, and particularly ways to think about using ancestry information to better put error bars on information that's returned to patients. That might be an interesting space for us to consider exploring in the future. I suspect there probably are algorithmic approaches for doing that. I think another area related to actually developing those approaches would be the communication aspects for patients and providers, and ensuring that they understand that information that's coming back to them around those error bars. And last, I hate to even bring the word electronic health record up, but I will say that in 2010, NHGRI and a number of federal partners went through an extreme amount of effort to brush up the U.S. Surgeon General's My Family Health Portrait family history tool to be able to capture risk information from people's families, store it in a codified, standards-based format, transmit it through Microsoft Health Vault to Mayo clinics for utilization for risk interpretation. Fast forward essentially another decade, that was to be a proxy for the conversation about making it possible for genomic data to be that portable. We are not there yet. We're not even close, I don't believe, in most settings. So the question would be, does the DTC and consumer genomics movement, with its large amounts of information and perhaps 100 million consumers in the relatively near future having data potentially somewhere in some system, provide incentive that didn't exist before for EHR companies to think about coming to the table to re-energize the conversation about standards for portability and accessibility and maintenance of genomic data, particularly in the context of healthcare systems. So with that, other thoughts?
I did have one more thought, and it was more back to kind of the chasm between having the test and moving it into clinical practice. And we talk a lot about education and provider education, and I feel like my head is like there's a hole in the wall from banging it against the head so long on this topic around this. And I wonder if we can reframe it a little bit, because really that's one piece that needs to be done if we truly want to try to integrate it and back into the clinical setting. So it's like thinking more about from the implementation science standpoint and thinking about all the things that actually need to be necessary to move that into practice. I think it's probably a better way for us to frame it. Education's a piece of it, but again, I think it's hard for us to like say, once again, we're going to solve that problem and it's miraculously going to be able to be utilized by physicians or other providers, and that's going to be great. So, I mean, and you brought up the EHR as just another example of that issue as well. So that's the only thing I wanted to add.
You are dismissed. Have a good evening.